So without further ado, Community College Oncology with Dr. Sorah, caring for patients with melanoma and other skin cancers. All right, we've got a little bit of bioinformation on Dr. Sorah, but let's get right into some of the key things we should know. Dr. Sorah is a medical oncologist and clinician educator at UNC Lineberger Comprehensive Cancer Center. Dr. Sorah, welcome. So glad to have you here today.
Thanks, Tim, for having me.
Absolutely. Let's find out a little bit more about you. Specialize in the care of patients with GI cancers and melanoma. And Dr. Sorah is mostly patient-focused, but also serves as the oncology inpatient service leader for Lineberger. He's very involved with the Hematology Oncology Fellowship Program and is a career goal advisor for fourth-year medical students. And in your spare time, enjoy spending time with your wife and 2 sons running and hiking. So in addition to that, tell us what got you interested in healthcare generally, cancer specifically, and what was the road to your career as a physician now?
Sure. So basically, when I was probably 5 years old, my best friend at the time was diagnosed with a brain cancer.
Oh, boy.
And it turns out he actually passed away from that cancer a few years later. So having seen him go through that process and see his parents go through that process, you know, as a young kid, I wanted to be the one to cure cancer.
Yeah.
And then when he passed away, that kind of fueled my interest in thinking about medicine. And as I got older and realized that curing cancer is a lot more complicated than just saying, I'm going to cure cancer, I started studying biology and the science of medicine, the science of cancer, and discovered that I not only am interested from a personal perspective, but also I actually really enjoy the science behind how cancer is how it's created and how it's treated. So then went to medical school with that lens in mind that I thought I wanted to be an oncologist.
Okay.
I originally thought I wanted to do pediatric oncology.
Okay.
And then quickly realized that my interest is more in adults than in kids.
Gotcha.
So I went to medical school at VCU, and then I've done all my other training here in North Carolina at the Lineberger.
Great. And I think that's not unusual for clinicians to start out thinking they're going to do one thing and then find out they've got a totally different interest that really speaks to them.
Absolutely. And then you get into the specifics of something and you're like, that just doesn't feel quite like me.
Yeah.
But this really just resonated well with me.
Well, we're glad you found what you wanted to do, and we're glad you're here today.
Thanks, Tim.
Introduction to Immuno-Oncology and Advanced Melanoma with Dr. Sorah, and I'll turn the controls over to you.
Perfect. Good morning, everyone. Good afternoon, whenever you're watching this, and thanks so much for joining. So my goal for today is to talk about basically 2 areas of cancer that I deal with a lot. And one of those is immunotherapy and immuno-oncology. We'll talk about what that means, how that is integrated into the care of patients specifically with melanoma. And then we'll also talk about advanced melanoma, the workup of such, the treatment of such, and then kind of how to diagnose it as well. As Tim said, I am a medical oncologist, meaning that I use medicine to treat cancer. And I work very closely with my surgical oncology colleagues as well as my radiation oncology colleagues to take care of patients with melanoma. I also see patients with GI cancers, so colorectal, gastroesophageal, neuroendocrine tumors, and liver cancers as well. Okay, so as I said, my objectives for today are to discuss the workup of melanoma, to talk about the staging system for melanoma, how we decide how localized or advanced a cancer is, to compare the different types of treatments for melanoma, and we'll talk about the kind of, the stuff that's out now currently, and then talk about some stuff that's coming down the road as well. And then also to spend some time talking about immunotherapy, what it is, what the side effects are, how it works, and how it can actually be a very effective treatment for melanoma. Okay, so to start with, I kind of wanted to get a sense of people's understanding of what immunotherapy is before going into this lecture. So my first question for you guys is, as a poll question, is what is immunotherapy? And is it A, when we replace a patient's immune system with a lab-synthesized immune system to fight cancer? Is it when we recommend nutritional supplements to improve a patient's immune response to cancer? Is it when we use a medication to augment a patient's immune response to cancer? Or D, I just don't even know what immunotherapy is. So the answer is C. And as we go through our lecture today, we will figure out, why this is the right answer and kind of delve into the details of this a little bit more. Okay, so first of all, let's talk about what melanoma is. So melanoma is one of the types of skin cancer. The two more common types of skin cancer are squamous cell cancer and basal cell carcinoma. Those are much more common than melanoma. Though melanoma is a common cancer, it's the fifth most common cancer in the United States that we see. And the reason that we spend extra focus on melanoma versus the other two common kinds of skin cancer is because it has the highest chance of spreading to other parts of the body or metastasizing. And it can be a very aggressive cancer, and it actually, in the past and even currently, is a cancer that can be a life-limiting process. So as far as types of melanoma, there are four main types. The most common type, and this is probably 70-80% of melanomas, is what's called superficial spreading melanoma. And that's basically typically on sun-exposed areas. It's usually lesions that start small and then they kind of grow over time. They don't tend to grow really quickly. The second most common type of melanoma is called nodular melanoma, and that is probably somewhere between 10 and 20% of melanomas. This one tends to be bigger at the time that it's diagnosed. It tends to spread earlier, and this one can actually come up on non-sun exposed areas. So we will often find these on the back, the stomach, arms, depending on the patient. The third most common type of melanoma is called lentigo maligna, and this most commonly presents on the scalp. It's usually seen in older patients and again is related to chronic sun-exposed skin. It tends to be the most indolent or the most slow-growing type of melanoma, and thankfully is also one of the more treatable types. And then lastly is called acral lentiginous melanoma, and this is a melanoma that's often found under the nail beds. We find it on the palms and the soles, and unfortunately this tends to be the most aggressive type of melanoma because it's often found late because people aren't looking under their nail beds or under the bottom of their feet. This is the most common type of melanoma that we find in patients who have a more pigmented skin. So if you, as a primary care provider, for example, or as someone in the community trying to figure out if a spot is concerning for a melanoma, there are kind of a couple of rules that you can think about. So when I was a resident as doing primary care, there were two sets of rules that we went by to look at and evaluate for melanoma. The first is what's called the ugly duckling sign, and that's if you have a patient who has a lot of different spots on their skin. If one of them looks different than the rest, if it's, quote, an ugly duckling, that should raise your suspicion that it could be something else. And those folks you should either biopsy or send them to a dermatologist to have them think about biopsying this spot. The other kind of rule that we use in primary care and also in oncology is what's called the ABCDE criteria. And basically that is easy rules for you to look at a spot very quickly and tell if you think there's the possibility of melanoma. So as an example, I put a common looking melanoma on the right upper corner there, and we'll go through the ABCDE for this one. So A stands for asymmetry. That means that if you divide it in half, that one side looks different than the other. That should raise your suspicion. Number two is the borders. Are the borders irregular? So typically non-cancerous spots have nice, smooth, clean borders, whereas cancer spots typically have irregular, jagged type borders, which is something you would see on this picture. Number three is color variegation, and that basically means that within the same nodule or lesion that we see multiple different colors. Typically a non-cancerous spot has one uniform color, so when you see lots of different colors, that's concerning. Part D is the diameter. So a diameter of 6 millimeters or greater, which is about the size of a pencil eraser. Anything bigger than that should also raise your suspicion. And then E is evolution, meaning that the spot is changing over time. If you're seeing multiple of these A, B, C, D, E criteria within one spot, as the patient tells you or as you do your physical exam, those should raise your suspicion that this needs to be biopsied to make sure it's not something more than just a mole or more than just a non-cancerous lesion. So next, to think about, let's say you get a biopsy, you diagnose a melanoma. The next thing you need to do is stage the melanoma. And everyone has heard of cancer staging, and it goes from stage 1 to stage 4. But there's a lot of nuance into how you actually stage a melanoma. In most types of solid cancers, and when I say solid cancers, I mean anything that's not a leukemia, a lymphoma, or a myeloma, we use what's called the TNM staging system. And that stands for tumor, node or lymph node, and then metastasis. So for the T stage, so the tumor staging, the most important thing that we look for in a melanoma is how thick the cancer is, meaning how deep the cancer goes from the top epithelial layer down to where there is no longer cancer. So that's a very important characteristic because as the cancer gets deeper, as I'll show on the next slide, the risk of the melanoma spreading or potentially even being a life-limiting disease goes up. The other thing we look at for the melanoma itself is what's called the ulceration, and that's basically if the very top layer of the skin is called the epidermis. If that top epidermal layer has been removed because of the cancer, that's a high-risk feature, and that's how we designate that with an A or a B. So a deep ulcerated tumor is a higher risk cancer than a thin, non-ulcerated tumor. So that's the T stage. For the N stage, that's based on the lymph nodes. And there's a lot of different ways that we can get lymph nodes. Typically, we either do it by imaging, which we'll talk about, or we do it via biopsy, meaning that our surgeons, when they're removing the cancer, will actually remove some of the lymph nodes of concern as well to see if there is any cancer in them. And that we won't go into the details of that, but that having a lymph node positive cancer increases the risk that the cancer could spread as well. And then the third part of the TNM is the metastasis, meaning that the cancer has jumped from one place and has spread to another part of the body. And the basically where the cancer has spread also indicates how high risk of a cancer it is, with brain metastases being the most high risk, liver metastases being the second most high risk, and then other skin spots being high risk, but the least high risk of the M category. So the reason that we do staging is, number one, is it allows us to know exactly where the cancer is and where it's not so that we know what we're focusing our treatment on. And then number two is it also gives us prognostic information. It tells us, what is the chance that this cancer is going to recur at some point. So if you look at this graph here on the left, I just siphoned out some data for stage 3 melanoma. So stage 3 typically means that there are lymph nodes, so regional close by lymph nodes involved, but that there's no cancer elsewhere. And as you can see that as the stage 3 goes up, meaning that there's more lymph nodes involved or that the cancer is a bit thicker, the prognosis gets worse. And even as you can see here, the difference between 5-year survival of stage 3A melanoma being 93% versus a stage 3D melanoma being only 32%. And then on the right here, I just wanted to point out that as the cancer gets thicker, the prognosis gets worse as well, and that's indicated by the T stage over here, with a T1 melanoma having a 5-year survival of 99%, and an T4B, meaning a thick melanoma that it's ulcerated, having a prognosis of about 82% based on the most recent data that we have. Okay, so once you've done your biopsy, once you've done your staging workup, the next is to think about the general workup of other things that you need so that you can help your patient come up with the best treatment plan. So number one, and we already sort of talked about this, is having the pathologic staging, meaning to have the biopsy looked at by a dermatopathologist. So a dermatopathologist is a physician who specializes in looking at the biopsies of the skin. It's a specialization through pathology, meaning looking at laboratory medicine and looking at tissue. Number two is we want to evaluate for what's called a BRAF mutation. So a mutation is basically any change in the DNA of a cancer cell. DNA being kind of the book that tells you how to create a cell. So when we have changes in this specific mutation called BRAF, as we'll talk about in a few minutes, that can have implications for treatment. Number three, we have to get imaging studies. So for cancers that are deeper with more ulceration, or if there are lymph nodes involved, we will get full body imaging just to make sure that we're not missing cancer that could be somewhere else that the patient and the provider has not been able to detect. We typically use what's called a PET CT. So PET CT is basically, I describe it to patients as a kind of a fancy CT scan, where instead of giving contrast, which helps you to see things better, it actually uses a sugar, what's called fluorodeoxyglucose. And that sugar goes everywhere in your body that's overactive. And that part of your body takes up the sugar and it, quote, lights up on a scan. Places that do this are cancer, because cancer takes up more sugar, needs more energy than a regular part of your body. And then we also see increased uptake in things like infection and inflammation. So just because something lights up on a PET scan doesn't mean for sure that it's cancer, but it certainly raises your suspicion. And PET scans are much better than CT scans generally to do for your initial staging. The other thing that we will do is get what's called a brain MRI. So this is to look specifically in the brain, because as I mentioned earlier, melanoma does have a tendency to spread to the brain. A PET scan is not a good test to look in the brain because, as I'll show you some pictures of PET scans later, the brain takes up so much sugar that it's very difficult to see if there's anything up there. So that's something that we will routinely get, especially if someone's having any type of symptoms to suggest that. Number 4 is genetic testing. So melanoma is not generally considered a hereditary disease, meaning something that you can get from your parents. But there are cases where we do see that. So if the patient has lots of family members who have melanomas and there isn't an obvious cause, then we will often refer those folks to genetic counseling. I also tend to refer much younger patients to genetic counseling, specifically if you're in your teens or in your 20s when you're diagnosed. And then number 5 is what's called molecular sequencing. And I'm sure a lot of you guys have heard of the term precision oncology, meaning that we're trying to figure out how to individualize patients' cancer care. So the way to do this is to do molecular sequencing, which basically means we take the patient's biopsy and then we send it to a lab. And they basically go through the DNA and try to find specific changes in the DNA called mutations. And specifically, we're looking for things that either give us prognostic information, or if there are mutations that we have medicines for, those are helpful to know as well, just so I have a complete understanding of what the different types of treatments are for that patient. Okay, so after you've done all of that, I wanted to make sure I give credence to the fact that there is no patient that doesn't need a multidisciplinary team for their cancer care. I rely very heavily on all of these different specialties to help me take care of patients. And I think it's really important that when a patient is diagnosed with a cancer that they have a multidisciplinary team. I use my surgical and radiation oncology colleagues regularly. We use dermatology, obviously, dermatopathology. My pharmacists are very helpful in making sure there are no drug interactions with the medicines that we are giving. And then, there are lots of people behind the scenes as well, from the nursing staff to the infusion staff to the financial aid people. It's a large team of people that helps to take care of our patients. And I think it's really important that even though the provider tends to be the person who's kind of at the forefront, that I often make sure I give credit to all the people that are making the patient's care operate smoothly and efficiently. Okay, so we've talked about what melanoma is, what the staging of melanoma looks like, and what the workup is. Now let's delve into talking about treatment of melanoma. And we'll first kind of start with medicine to treat cancer, and then we'll move into some surgery options as well. So when I'm talking to residents or fellows or medical students about cancer therapy, I usually put them all into 3 buckets. And most of the cancer medicines that we have now fall into one of these 3 buckets. The first medicine to treat cancer is, as most people know, is chemotherapy. So chemotherapy is any medicine, and there are pill and IV or by vein versions, that goes around to the patient's body and kills cells that are dividing too quickly. So that can obviously be cancer cells, which is our goal, but it also kills other types of cells, including hair cells, GI cells, which can cause things like diarrhea and nausea, and also can affect the bone marrow, which lowers people's immune systems and ability to fight infection. It does this very non-specifically. It's not specifically attacking the melanoma or whatever cancer cells specifically. Number two is what's called targeted therapy, and that is where we use our sequencing, our molecular testing, as I talked about earlier, and we're trying to find whether we have a medicine that goes along with a target within that patient's cancer. And there are lots of options for that, and that's really where we're trying to get with oncology, is being able to personalize patients' care based on what targets they have. And then number three, which we'll talk about in a few minutes, is what's called immunotherapy. So immunotherapy is basically using a medicine to augment or to increase a patient's response against a cancer. And there are lots of different options for how we use these, and we'll spend a lot of time talking about these in a few minutes. And there's different ways that you can actually work on the patient's immune system. So there are IV medicines that work through that. And then the other one that we actually use a lot in melanoma is actually using oncolytic viruses. Oncolytic meaning cancer-killing viruses. The one that we use in melanoma is called T-VEC, and we basically inject the virus directly into the cancer, and it allows the immune system to be recruited to that area to treat the cancer. Now, if we think about melanoma, thankfully, chemotherapy actually doesn't work very well in melanoma, and that's a lot of the reason that before we had targeted therapy and before we had immunotherapy, melanoma had a very poor prognosis because it doesn't respond particularly well to chemo. So I actually don't use very much chemotherapy for my melanoma patients unless we've run out of other ideas. Okay, so let's talk about immunotherapy. I keep mentioning this term. So immunotherapy, as I said, is a medicine that basically allows your body, your immune system, to see the cancer as something that shouldn't be there. And if you look at this schematic on the left side here, you'll notice at the bottom of the diagram there are two proteins. One is called PD-1, and PD-1 is a protein that's found on the top of T cells, which is part of your immune system. And then your cells, so normal body cells, as well as tumor cells, have a protein called PD-L1. And when PD-1 and PD-L1 come together, basically that tells the T cell to not attack whatever cell has the PD-L1 on it. And now cancer cells are smart. They're derived from our cells, so they have a lot of the same proteins on them. So they have figured out how to evade our immune system via this PD-L1 mechanism, among other ways as well. So the idea behind immunotherapy is that what if we block PD-1? What if we block PD-L1? If we block that turn-off signal, so then we would actually allow the T cell to stay turned on, and then the T cell would actually attack the cancer cell. So that's the idea behind immunotherapy, and there are lots of different immunotherapies. I've listed a few here on the right. Most folks have heard of some of the PD-1 inhibitors like pembrolizumab, or you may have heard of it known as Keytruda, or nivolumab called Opdivo. There are commercials for these as well as for some of the others. So as you can imagine, if we are targeting the patient's immune system and kind of revving up the patient's immune system to fight cancer, that can cause side effects. And I use this diagram every time I give a lecture on this because this is exactly how I learned about immunotherapy, that it can really cause inflammation or any kind of toxicity to any organ in the body. The most common side effect of immunotherapy is actually fatigue, where folks just feel a little bit more run down than usual. It's not typically the right after treatment. It's normally kind of throughout the course of their treatment. The second most common side effect is things like skin rashes, if you get inflammation or basically an autoimmune attack on the skin, and then dry skin is also very common. Number three is it can cause diarrhea if you have inflammation towards the colon, which is called colitis. And then number four is what's called hypothyroidism, or problems with the thyroid, which is a gland that sits in your neck that affects your metabolism. Now, those are the most common things, and I always tell patients about those. But less common than that, we can see, as you can see on this schematic, inflammation of other organs as well. So liver toxicity or elevation of the liver function numbers is possible. We can see inflammation of the lungs, the kidneys, the brain, the spinal cord, the muscles, the joints, you name it, it's a possible side effect that we've seen. Now, thankfully, most of these side effects are reversible, meaning that if we were to stop the drug and let the patient's immune system calm back down, that the side effects tend to go away. Sometimes we do have to give the patient immunosuppression to calm their immune system back down, and that usually takes the form of steroids or sometimes even more sophisticated medicines than that. The main types of side effects that don't go away are what are called in my mind, the hormone side effects. So those are things like the thyroid. So if the thyroid's affected, it doesn't tend to get better, and then you usually have to take medicine for the rest of your life for that. The pancreas, which makes insulin, so that can cause a rare complication, sort of like type 1 diabetes. That's less than 1% of patients. And then the other two I always tell people about is the adrenal glands, which make steroids, and the pituitary, which makes hormones and steroids as well. If any of those organs are affected, you typically have to use lifelong medicines to replace those components that are missing. Now, with immunotherapy, the risk of these toxicities depends on which immune therapy you are using. So as I said here, the risk of a grade 3 toxicity, and grade 3 is defined as having to stop the drug permanently because of side effects, having to admit the patient to the hospital because of the severity of their side effects, or having to put the patient on steroids. That's typically how most trials, clinical trials, call grade 3 toxicity. The risk for one immune therapy by itself is about 10 to 15%. So that means, 85 or 90% of patients do not have grade 3 toxicity. Whereas if you're giving two immunotherapies together, the second one being ipilimumab and nivolumab, which is a very common double combination we use in melanoma, the risk can be up to 50% of patients. And then there's a newer combination at the bottom that has about a 25% risk of running into problems. So these are real toxicities, and these are things I see a lot. But you counter the risk of toxicity with the possibility of durable cancer control. And I've just listed the clinical trials that got these medicines approved at the bottom. Okay, and this is just an example of how we think about treating immune-related toxicities or immunotherapy side effects. This comes from the National Comprehensive Cancer Network. They have a really good website for going through how to grade side effects and how to treat them. So this here is specifically is pneumonitis, which means inflammation of the lungs, which is a fairly common side effect that we can see with immunotherapy. And as you can see, it tells you what to do for grade 1 or mild toxicity. You just hold the immune therapy and see if everything calms down. Grade 2 means that it's causing somewhat significant symptoms, or if it's involving a little bit more of the lungs, that's when we think about using steroids sometimes. And then grade 3 means the patient needs to be admitted or is on oxygen, and those folks require permanent discontinuation of the immunotherapy, sometimes steroids, sometimes more than that. And there's one of these for almost every immune-related toxicity, at least the major ones. But I find this very helpful, and I reference this a lot when I run into these problems with my patients. Okay, so that's immunotherapy in a nutshell, and a very common medicine that we use to treat patients with melanoma. The other type of medicine that we use a lot in melanoma is what's called targeted therapy. And as I said earlier, targeted therapy is a medicine that specifically attacks or targets a protein within the cancer that we know the patient has. As I said earlier, the most common mutation or change in the DNA that we see in melanoma patients is called a BRAF mutation. More specifically, it's a BRAF V600E. And V600E just indicates which amino acids or the building blocks of proteins have changed. And as you can see on this schematic, which of course you don't need to know, what this is showing is basically the very top is showing outside of a cell. The kind of white circles is showing the cell membrane. And then within the cell membrane, you can see a pathway that basically is one of the signaling mechanisms for how a cancer cell knows to grow or how a normal cell knows to grow. And in melanoma, since 50% of these patients have a mutation in the BRAF gene, which is that green circle down there, that basically, if that protein gets activated or has a mutation in it and starts signaling when it's not supposed to, it keeps sending that signal down into the nucleus, which is at the bottom, and tells the cancer cell to divide. And that's how cancer perpetuates, is that it has a signal that says keep growing, even though the body is not giving it that signal. So what we've learned is that if you actually use a targeted medicine towards the BRAF mutation, and there are 3 examples there. The most common one that we use now is called encorafenib. These are pill therapies. These are not IV infusions that we can actually get cancer control. And then what we've learned as well is that if we actually block two different proteins in the pathway with both BRAF inhibitors and MEK inhibitors, which is the next protein down, we can get even better cancer control. And it actually has better side effects. So the combination of encorafenib and binimetinib are two pills that are used together to treat melanomas, and they are very effective. Okay, so we've kind of talked about chemotherapy a little bit. We spent some time talking about immunotherapy, and then we also talked about the most common targeted therapy in melanoma. So let's take that, all the stuff that we've learned so far, and think through how you would treat a patient with melanoma. So for people that have stage 2 or stage 3 melanoma, stage 2 means that it's a very thick cancer, but there's no lymph node involvement. And stage 3 means that there is local lymph node involvement of the cancer. The standard of care for these patients is surgery to try to remove the cancer that's in the spot that it started, as well as in the lymph nodes around it. And we'll talk about what that means as well. So basically, the removing the primary tumor is what's called a wide local excision. So basically, the surgeon makes a margin around the cancer to make sure that they get not only the cancer, but they get some of the normal tissue as well to make sure they got everything. And they usually have to do it fairly deeply as well. And then, if the tumor is 0.8 millimeters or deeper, which they often are, the surgeon will do what's called a sentinel lymph node biopsy. So what a sentinel lymph node biopsy is that by physiology, the cancer, let's say it's on your arm, the most common place that the cancer would spread first would be to the closest lymph nodes that are towards the body. So that would be the armpit or the axillary lymph nodes. So what the surgeon does is they actually inject a dye into the primary tumor, and then that dye actually travels through the lymphatic system up into the closest lymph nodes. So what they do is then they use a special machine to actually measure where that ink has gone, and then the surgeon will extract the lymph nodes that the cancer or that the ink has drained to, and then our pathologist will look at it. That's the theory behind a sentinel lymph node biopsy. This is something that's used not only in melanoma, it's also used a lot in breast cancer is the other place that we see this a lot. Okay, to kind of narrow down on things a little bit more, the treatment of stage 2 and stage 3 melanoma has actually gotten a lot more complicated. The way that we used to do this, and the way that we still do in some ways, is we actually focus on giving surgery first, so surgery plus or minus sentinel lymph node biopsy, and then we think about adjuvant therapy after surgery. So adjuvant means in addition to. So what adjuvant therapy is medicine, so that's where I come into play, to help reduce the risk of the cancer coming back. So the thought is that even though you've removed the tumor, you've removed the lymph nodes around it, there could still be theoretical cancer cells floating around either in the lymph system or in the bloodstream. So we use medicine to try to reduce the risk of that cancer moving somewhere else and spreading and taking root and then starting to grow. So for stage 2 cancers as well as smaller stage 3 cancers, we do surgery first and then do medicine afterward if we decide to do it that way. If the patient has a BRAF mutation, so they basically have that targeted treatment available to them, we would either offer 1 year of immunotherapy by itself, and that's, as I said, an IV infusion. It's typically done every 3 or 4 weeks for a year. And then the other one would be what's called targeted therapy, so that would be using the encorafenib and the binimetinib for 1 year. If the patient does not have a BRAF mutation, then you don't have the chance to offer the patient the targeted therapy, and then you would offer the patient a year of immunotherapy. After that year, they would go on what's called close surveillance, meaning skin checks regularly, imaging regularly, just to make sure that the melanoma doesn't come back. Now, on the other side, we have what's called neoadjuvant treatment. Neoadjuvant means before surgery, so that's thinking about giving medicine before surgery. When would we think about doing that? We often think about doing that for patients who have really large cancers, where it would be helpful to shrink the cancer to make surgery easier. If the patient has bulky, big lymph nodes, particularly if they're more than 1 centimeter in size, we often will try to give immunotherapy up front to help kind of prime the patient's immune system to fight the cancer. It sometimes can downstage the tumor, making it smaller and easier to remove. And then it also has been shown that giving immunotherapy up front actually decreases the risk that the cancer is going to spread somewhere else. So there's been a lot of excitement about using immunotherapy before surgery, and that's becoming a standard of care both here at Lineberger as well as nationally. And that can be given either as single agent immunotherapy or even giving combination immunotherapy as well. And that, of course, has all of the attendant side effects of what we talked about earlier. Now, stage 4 melanoma. So this is when the cancer has spread to other parts of the body. So there's 3 ways to treat cancer. This is how I talk about cancer with every one of my patients. Number 1 is surgery. So if the patient only has a couple of sites of metastasis, then we will sometimes think about surgery up front, particularly if they have really painful areas or if they're draining or if they're getting infected. Those would be reasons to think about that. Or if the patient has a single brain metastasis, we will sometimes surgically remove the brain metastasis first. Number 2 is radiation. We don't use radiation a lot in melanoma, but it is helpful if people have spots that are painful or if an area is growing really quickly and we want to try to shrink it quickly and give immunotherapy time to work. Because immunotherapy actually takes usually a couple of months to really kick in and start working. And then number 3, which is where we focus most of our time in stage 4 disease, is to use medicine to treat the cancer. And that's what we've talked about already. Okay, so and then just to kind of give you big picture ideas of how we treat melanomas when they're stage 4. As I've said before, we look for the BRAF mutation status. So if they have a BRAF mutation, which is the left side, you can either offer the patient BRAF or MEK inhibitors up front. We often will do that for people who have really symptomatic disease, if they're losing a lot of weight, if they're having a lot of pain, if the cancer seems to be growing really quickly. BRAF MEK inhibitors work faster than immunotherapy, so we'll use it in that situation. In less aggressive disease, when you don't fit any of those specific categories, that's when we would use immunotherapy up front. Now, generally, our goal is to use immunotherapy if we can. There is some data, actually a trial just a few years ago, that showed that giving immunotherapy before using targeted therapy actually has a survival advantage. It actually helps patients live longer. So we really have to talk ourselves into why we wouldn't use immunotherapy for a patient. And that could either be because the cancer is growing quickly or if the patient has any contraindications to think about immunotherapy. And then if they don't have a BRAF mutation, upfront immunotherapy is our first treatment option. Okay, so I just want to go through a couple of cases. These are all patients that I've seen, and that just to kind of give you a sense of how these treatments work and how the side effects go. So case number 1 is an 81-year-old woman with a history of fairly well-controlled rheumatoid arthritis who had a stage 3 melanoma of her back in October of 2022. She met with me. And after we kind of talked through the risks and benefits of immunotherapy, she decided that she did not want to take any immunotherapy to reduce her risk of cancer recurrence. So I started following her with PET scans, and she actually showed up for a PET scan for a routine visit with me. And it turns out that she had multiple lymph nodes throughout her body that were lighting up on the PET scan and were very suspicious for metastatic disease. She had a brain MRI that was negative. And then even at this point, she had no idea this was happening and was living independently, hiking. She lived down at the beach and was actually doing really, really well overall. So I sent her cancer for mutation testing, and it turns out that she did not have a BRAF mutation. So to kind of think about knowledge and see kind of what you guys have learned from what we've done so far, I thought this would be a good place to put a question in. So what is the next best step in her care? So non-BRAF mutated, has some metastatic disease, but is fairly active and doesn't have really evidence that she's got metastatic disease. So the answer A would be BRAF MEK inhibitors, B would be ipilimumab and nivolumab, C would be nivolumab by itself, or D would be best supportive care or hospice. So the answer here is ipilimumab and nivolumab, and the reason for that is because the patient doesn't have a BRAF mutation, we cannot use BRAF and MEK inhibitors. And then typically for a patient who's 81 years old, otherwise healthy, best supportive care would always be an option. That's something I certainly talk about with my patients. But I typically recommend that we at least try some sort of therapy, and she wanted to be aggressive with her treatment. So typically, if people are coming and they're really sick and in bed a lot, those are people that I would think about hospice up front for. And then number for C, nivolumab, typically giving one immune therapy by itself does not give us the response that we are hoping to get for someone who's otherwise healthy and active. Okay, so this is her PET scan. So the left side is her PET scan that I was telling you about, where she's got multiple lymph nodes involved. And basically, the way to read a PET scan is what you're looking for is areas of white or yellow. So if you look at her liver, which is kind of that oblong thing in the middle of her of the scan, you can see some yellow and some white kind of right beside her liver. Those are lymph nodes. Those are called periportal lymph nodes, and those were all showing evidence of cancer. You can also see that up near her right collarbone, she has some evidence of cancer, and then she has some lymph nodes in her mediastinum, which is the middle of her chest, that are all suspicious for cancer. As I said earlier, the brain is not well encapsulated on a PET scan. That's actually a normal brain finding where basically there's so much sugar uptake in the brain because it's so active that you can't really use it to determine if patients have cancer in their brain or not. So the patient got ipi-nivo, ipilimumab, nivolumab for 2 treatments. And after 2 treatments, as you can see, she had a complete response to therapy, meaning that there was no more evidence of cancer in her body. Now, unfortunately, with those 2 treatments, she did have a flare of her rheumatoid arthritis, which we can sometimes see that patients who have autoimmune problems such as rheumatoid arthritis, lupus, Crohn's disease, inflammatory bowel disease, those kinds of things, that we can see the immunotherapy actually cause worsening of those processes. So after 2 treatments, we actually decided to stop the double immune therapy and switch her to single immune therapy, and got her rheumatoid arthritis back under control, and she's doing really, really well now with no evidence of melanoma metastasis right now. She also had a very dry mouth, which is a common side effect that we can see with melanoma that can often need treatment. All right, and then my second case for you guys is another one of my patients. This is a 61-year-old gentleman who actually has a history of cardiac sarcoidosis. So sarcoidosis is an inflammatory scarring disease that's fairly common in North Carolina, and it's affecting his heart. But he otherwise is very healthy, and he presented with a rapidly expanding lesion on his back. And you could also see multiple other black spots popping up around his body. He went to dermatology, got one of these lesions biopsied, and it did confirm melanoma. And his cancer had a BRAF mutation, a V600K mutation, which is the second most common mutation we see in BRAF mutated melanoma. He had a PET scan that showed multiple sites of disease, including skin, bone, liver, lymph node, and then unfortunately he had multiple brain lesions as well, which were very suspicious for melanoma. So he, also like our last patient, was started on ipi-nivo. The reason we picked ipi-nivo instead of BRAF MEK inhibitors is because he really wasn't particularly symptomatic, and he had a V600K mutation, which tends to be a little bit less responsive to BRAF MEK inhibitors than V600E mutations. And basically, after his second treatment of melanoma, he called me and my nurse, and we actually brought him in for an urgent visit because he all of a sudden developed fever, a thickening of his neck, difficulty breathing, and tachycardia, or a fast heart rate. He also, we got some labs that day that were really unremarkable except for his thyroid lab, so affecting his metabolism, showed that his T3, which is the active thyroid hormone, was very elevated at 10.8, with the normal upper limit being about 4. And then his T4, which is the pre-activated thyroid hormone, was almost, 6 times upper limit of norm, being 11, where upper limit is typically 1.7. So, knowing that he's gotten immunotherapy recently, what do you think is the most likely cause of his hyperthyroidism? Okay, right. So this is a immune-related toxicity. So I talked earlier how the most common thyroid problem is typically hypo or low thyroidism problems, but we can also see hyperthyroidism, meaning that the thyroid gets overactivated because of the immune system as well. We do sometimes see that folks who have pre-existing thyroid problems can be kind of uncovered during a patient's immunotherapy exposure. However, it's fairly uncommon for folks to have hyperthyroidism as a result of that. Bad luck certainly is a reason. And then metastatic melanoma does not cause problems with the thyroid. So immune-related toxicity is the answer here. And then this is just a picture of his brain. So he recovered from his thyroid problems. Thyroid storm is what that's called, and got medicines to bring his thyroid production down. And then after those 2 treatments, we switched him to nivolumab, or 1 immunotherapy. And now he's been on that for over a year and doing really well. So on the left here, that's his brain MRI, where you can see those white spots. There's at least 5 that I can see there. And if you look on the right one, which is his most recent MRI, he doesn't have any evidence of brain metastasis. And that was with immunotherapy alone, not having to do anything else to treat the cancer. Okay, the last thing I was going to do, this is just kind of a random aside, but basically, I think it's helpful to know, how to become an oncologist and what does it look like to become a melanoma doctor or whatever kind of specialty you want to do within oncology. They all start with medical school, so you have to get either an MD or a DO degree. And then after that, everything kind of diverges. So as I said, I'm a medical oncologist, meaning that I'm medicine trained. So I did 3 years of internal medicine, and then you do a 3-year hematology and oncology fellowship. So that ends up being about 10 years after undergrad. Radiation oncology is typically 1 year of an intern year and then 4 years of radiation oncology residency. So that's 5 years total, or 9 years total after medical school. And then surgical oncology is using surgery to treat cancer. And those folks typically do 5 years of general surgery and then do a couple of years of specific surgical oncology training, which ends up being about 11 years of training if you don't need any fellowships after that. So it's a very rewarding field. It's a field that I love coming to work every day and being able to work with my patients and get to know their families really well. I see my patients a lot, so I get to basically be a primary care doctor plus, because I take care of people's other stuff as well in addition to their cancer care. And I couldn't imagine doing anything else. And I would look forward to you guys exploring oncology as a field. I think that's it.
Great. Dr. Sorah, thank you so much.
Of course.
We learned a lot. I do have a few questions and comments. I know you talked about the multidisciplinary team.
Yeah.
And so I want to just stress to our entire audience, because some of them may be considering becoming a physician or a nurse or going into imaging or pharmacy. And so it was just good to hear that all of those folks are working together for the patient.
That's right.
And I know we have one of the things that our team does is to help make sure that those multidisciplinary teams can meet on a regular basis, and all the different voices can be heard speaking up for the patients. So, I wanted to ask, what are some, as you look to the future, what are some of the most promising things that you're seeing out there or of greatest interest to you? Thinking, I know I recently saw something about an FDA-approved cell therapy called Amtagvi, if I'm saying that correctly,
yes, you got it.
for aggressive melanomas. Is that a little bit promising, very exciting, and tell us a little bit about that, and then anything else out there that you're looking forward to seeing more of.
Yeah, so we're very excited about this. This is a treatment that we've been looking forward to for over a year now.
Okay.
It's called TILS therapy, which stands for tumor infiltrating lymphocytes.
Okay.
So the idea behind it is that melanoma constantly has the immune system working on it.
Right.
So if you extract a melanoma that has immune cells in it, aka lymphocytes, so white blood cells, and what we do is we extract the biopsy of the melanoma, we take out the white blood cells, and then we expand those white blood cells in a lab.
Okay.
And then we would actually infuse kind of an expanded amount of those white blood cells back into the patient.
Gotcha.
And the idea is that you have a bunch of white blood cells that all of a sudden can attack the cancer, and is specifically designed to attack the cancer.
Okay.
And we're very excited about this FDA approval, because UNC actually is going to be a site that does this very soon. Good. So I've already been on some emails about what the next steps will be for that.
Great.
So that's one exciting treatment. After immunotherapy, and there's lots of different kinds of immunotherapy, that's one thing that we're working on is new types of immune therapy. The other thing we're working on is targets. So there are lots of other mutations or changes in the DNA besides BRAF, and as we get more and more of those medicines, and that gives us more options for our patients as well.
Gotcha. That's great. And I couldn't help but think as I was listening to your talk about just how the challenges and the rewards of you're really like a detective trying to
Yeah.
to sort out all of these things and then trying different approaches with the knowledge you have, but also having to really understand the patient and learning about the patient as you go as well.
Yeah.
Another question. This is a little off from the others, but so the other day I spotted something that sort of fit. I thought that A, B, C, D, E. So I thought, okay, better go see my dermatologist. Go in. Dermatologist pulls out something about this size with a little hole, and he looks through it and says, "Oh no, you're fine."
Okay.
What is that, and how is the dermatologist able to use that, and what sort of information do they get from that?
Great question. So it's called a dermatoscope or dermoscope, depending on who you talk to.
Yeah.
And it's basically a glorified magnifying glass.
Okay.
And it allows them to look really closely at specific characteristics on the lesion to see if
Gotcha.
they're worried about it.
Okay.
And we in oncology, unfortunately, are not trained in how to use those. So beyond that, I'm not exactly sure.
Gotcha.
But it allows them to try to figure out how to not have to biopsy things.
Gotcha. Well, good. Thanks for telling me a little more
Yeah.
about that. I think we should probably leave it there because we are running towards the end of our time. We want to, Sarah, thank you. So thank you to the North Carolina Community College System. We are really appreciative of this collaboration with them. And thanks to all the instructors at the community colleges who make this available to their students. Thank you to the North Carolina University Cancer Research Fund that funds our work and so much other work around cancer in the state of North Carolina. We want to thank the UNC Lineberger Comprehensive Cancer Center, our team, Venny Obore, John Powell, Oliver Marth, Andrew Dodgen, Patrick Muscarella, Lindsay Reich, and Barbara Walsh for all the hard work they do for all of our different lectures.